Have you ever found yourself wondering, truly wondering, how medical professionals see beyond the surface in a critically ill patient? How do they get that, continuous real-time picture of what's happening inside, deep within the organs, the blood flow, the very delivery of life-sustaining oxygen?
Mm-hmm.
It's way more intricate than just a quick glance, isn't it? It's this profound dance between, keen human observation and some truly advanced technology.
Right, absolutely.
The precise intersection, that combination of insight and innovation, is exactly what we're setting out to unravel today on The Deep Dive. Our mission really for this session is to take a comprehensive journey into the complex, vital world of physiologic monitoring. We're talking specifically about patients undergoing surgery or those in really critical condition.
Right.
We're using a rich set of medical sources as our guide here. And this isn't just about, passively absorbing information. This is about really understanding the nuances, grappling with the complexities, and synthesizing the insights. Doing it in a way that truly allows you to master this field.
Yeah.
Almost like becoming one of those elite professionals who navigate these critical decisions every single day.
That's a great goal.
We'll explore the whole spectrum, from the basic vital signs you see in any doctor's office, all the way to these cutting-edge technologies that are, frankly, reshaping what's possible in patient care.
And to truly get that mastery, that deep understanding, let's start with the absolute essence. What does monitoring even mean in a medical context? The English word itself, it comes from the Latin verb monere.
Well, monitoring, okay.
Yeah, which carries the meaning to warn or advise. And that ancient root, it perfectly captures its core purpose in modern medicine. We monitor patients primarily to detect subtle, often pathological variations in their physiological parameters.
So tiny changes that signal trouble.
Exactly. This isn't just data collection. It's about establishing an early warning system. It gives medical teams advanced notice, a heads up, about any impending deterioration in an organ system's status, maybe even multiple systems. The ultimate goal is always to empower the clinician to take appropriate, timely actions. This proactive approach lets them prevent or ameliorate severe physiological problems before they become catastrophic.
Right, stopping things before they spiral.
Precisely.
Yeah.
But beyond just sounding an alarm, monitoring is equally critical for titrating therapeutic interventions.
Titrating, meaning adjusting things carefully.
Exactly. Think about precisely adjusting the amount of intravenous fluids a patient gets, or carefully fine-tuning the infusion rates of powerful drugs like vasoactive or inotropic agents, the ones that impact the heart and blood vessels. These advanced monitoring techniques, you see them most routinely and extensively employed in two main places: the intensive care unit, the ICU, and the operating room.
That makes incredible sense. So in critical care, you hear about this almost aspirational concept, what clinicians might call their holy grail.
Ah, yes, the Holy Grail.
The ability to not just see what's happening, but to actually assess clinically relevant parameters of tissue and organ status in real time, and then crucially, use that precise knowledge to genuinely improve patient outcomes. It sounds like the ultimate goal, but I imagine it must be incredibly complex to achieve in practice.
It absolutely is. And this is where it gets really interesting, because while that Holy Grail is the guiding star, it comes with significant caveats and challenges. These really underscore the true complexity of the field. First, despite all the tech, there's often still a fundamental lack of consensus on what are truly the most appropriate parameters to monitor to achieve that big goal.
So we might be measuring things, but are they the right things?
That's the question. It's not always as simple as more data is better data. Second, and this is perhaps even more critical, the act of making an inappropriate therapeutic decision, whether it's due to inaccurate physiological data or maybe even a misinterpretation of perfectly good data, that can actually lead to a worse outcome for the patient than if you had no data at all.
Wow. That's a heavy responsibility, worse than nothing.
It highlights the profound responsibility that comes with these tools. So the highest importance, therefore, lies not just in the sheer collection of data, but in the integration of all that physiological information, putting it together into a coherent, evidence-based, and critically thought-out treatment plan. Throughout this deep dive, we'll thoroughly cover the current technologies that are making waves, and we'll even glimpse into some truly emerging techniques, things that might soon transition from research into standard practice.
Okay, so if we unpack this even further, it really seems the fundamental goal of all hemodynamic monitoring at its very heart boils down to one essential element: oxygen. Why is oxygen the absolute central focus here? It feels foundational.
Because oxygen is quite literally the fuel for life at the cellular level. You're spot on. The fundamental goal of all hemodynamic monitoring is to ensure a sufficient continuous flow of oxygenated blood through the microcirculation.
Those tiny, tiny blood vessels.
Exactly, those intricate capillary networks. We need that flow to support aerobic metabolism within every single cell in the body. The critical reason for this continuous supply is that mammalian cells, generally speaking, they just can't store oxygen for any significant period for later use.
No reserves.
Practically none. I mean, there's a minuscule amount stored in muscle tissue as oxidized myoglobin, but it's truly negligible for continuous function. This means that ATP adenosine triphosphate, the universal energy currency of cells, requires constant, unbroken delivery of oxygen.
Right.
This oxygen has to continuously diffuse from the hemoglobin within red blood cells, across cell membranes, all the way to the oxidative machinery inside the mitochondria, the powerhouses of our cells.
That's a whole delivery chain.
It is. And without that unbroken, continuous supply, cells simply cannot generate the energy they need to function. That leads to cellular dysfunction and, eventually, cell death.
So if that continuous oxygen supply is absolutely vital, what are the different ways it can break down? How can it become insufficient and cause that cellular distress?
That's the crux of the challenge, because there are multifaceted reasons for insufficient oxygen delivery. And this is precisely why effective hemodynamic monitoring needs to be so comprehensive, especially if you want to operate at that elite level of understanding. It could be due to inadequate cardiac output, right? The heart just isn't pumping enough blood volume to meet the body's demands.
The pump is weak.
Or the problem could stem from insufficient hemoglobin concentration in the blood. Think anemia, just not enough oxygen-carrying molecules.
Not enough trucks on the road.
Good analogy. A third major cause is inadequate oxygen content of the arterial blood itself. Maybe the lungs aren't properly oxygenating the blood due to respiratory issues, but here's where it gets really interesting and perhaps less intuitively obvious.
Okay.
Even if you have adequate cardiac output and even sufficient hemoglobin and arterial oxygen content, the perfusion of those tiny capillary networks, the microcirculation, can still be severely impaired.
How does that happen?
Well, it can happen due to a dysregulation of arteriolar tone. Those smallish arteries aren't constricting or dilating properly, so blood can't get to the cells. Or you might have microvascular thrombosis, tiny clots blocking these critical capillaries.
Those traffic jams.
Exactly. Another insidious cause is the obstruction of these nutritive vessels by sequestered leukocytes or platelets. Essentially, white blood cells or clotting cells get stuck and block the critical flow path. Therefore, comprehensive hemodynamic monitoring must take all these diverse factors into account. If it doesn't, it paints an incomplete and potentially profoundly misleading picture of what's happening at the cellular level. And that, inevitably, leads to inappropriate and potentially harmful clinical decisions.
That makes perfect sense. It's like a complex web of interconnected potential problems. So how does oxygen utilization, the VO2 you mentioned, relate to oxygen delivery, the DO2, in all of this complex picture?
It's a really critical relationship, absolutely central to understanding shock states. Under normal conditions, when the supply of oxygen, our DO2, is plentiful, our aerobic metabolism, the actual oxygen utilization, VO2 functions independently of how much oxygen is being delivered.
The cells just take what they need.
Precisely. In that healthy state, VO2 is primarily determined by the body's metabolic demands, maybe the hormonal state or the mechanical workload of tissues, not simply by the incoming oxygen supply. However, in pathological circumstances, when the availability of oxygen becomes inadequate, that's when VO2 becomes supply dependent.
Okay, so utilization starts tracking delivery.
Exactly. Our sources illustrate this beautifully with a graph, figure 13:1, which is key to understanding this balance. Imagine DO2, oxygen delivery, on the horizontal axis and VO2, oxygen utilization, on the vertical. In the upper region, where DO2 is high, the line plotting VO2 against DO2 is nearly flat, almost zero slope.
Independent.
Right, signifying that VO2 is largely independent of DO2. But as DO2 decreases, you hit this crucial transition point, which we call the point of critical oxygen delivery, or DO2 crit.
Tipping point.
Kind of, yes. Below this DO2 crit, the line dramatically changes slope. It becomes non-zero and positive. This shows that VO2 is now directly dependent on DO2. What this means in practical terms is, below this critical threshold, the body's compensatory mechanism, its ability to extract more oxygen from the blood passing through, simply cannot keep up with the deficit in delivery.
The reserves are tapped out.
Exactly. As a direct result, overall oxygen consumption by the tissues begins to decrease, signaling cellular hypoxia. And interestingly, the steepness of that supply-dependent region on the graph actually reflects the maximal oxygen extraction capability of the specific vascular bed or tissue being looked at. It's a powerful visual metaphor for this fragile balance of oxygen supply and demand.
That brings us perfectly to part one, foundational monitoring. Let's start with something every single one of us has experienced. Arterial blood pressure seems like such a fundamental, simple, vital sign. But what's truly fascinating here, how complex is it really, beyond just those two numbers?
You're absolutely right. While arterial blood pressure is, a cardinal parameter in hemodynamic monitoring, its extremes, whether too high or too low, are either intrinsically damaging to the patient or a strong indicator of a serious underlying physiological issue. What's often missed, though, is that blood pressure is a complex function of two primary factors: cardiac output, the volume of blood the heart pumps, and vascular impedance, essentially the resistance within the entire arterial system.
Okay, this leads to a common but frequently incorrect misconception that a normal blood pressure automatically guarantees adequate cardiac output and sufficient blood flow to the tissues.
Oh, that's a key point for someone wanting to master this.
Absolutely. This assumption is, in fact, frequently incorrect in critically ill patients. And this is precisely why these patients very often require additional, more advanced forms of hemodynamic monitoring beyond just a simple blood pressure reading. Now, concerning non-invasive techniques, the classic time-honored approach is manual auscultation, listening for those Korotkov sounds.
The stethoscope in the cuff.
Exactly. It's a fundamental skill. Inflate the cuff, then slowly deflate it. The first tapping sounds you hear, systolic, the point where they disappear completely, diastolic.
Now, what about those automatic cuffs that are just everywhere now, in the clinic, at the pharmacy? Right, those largely use oscillometry. This method detects tiny oscillations in the pressure within the cuff's bladder as it gradually deflates. It's incredibly simple and particularly useful in noisy environments. Think a busy ER or a medical helicopter where hearing those Korotkov sounds clearly might be impossible. However, our sources emphasize a critical point here. For precise clinical decisions, this approach is, and I quote, neither accurate nor reliable enough to be universally trusted.
Okay, so convenient, but maybe not for critical adjustments.
That's a fair summary. For simpler pulse detection, like estimating just the systolic pressure, other reliable non-invasive methods exist. You could use a Doppler stethoscope, which gives an audible, amplified signal of blood flow, or even a pulse oximeter, where the reappearance of a pulse is indicated by that flashing LED. Automated devices for repetitive, non-invasive blood pressure measurement, they vary in their technology. Some, as we said, measure pressure oscillations in the cuff. Others might use a piezoelectric crystal placed over the brachial artery. The accuracy of all these devices is variable and, crucially, depends on proper cuff size. This is vital.
Right, the cuff size matters.
Hugely. If the cuff is too narrow relative to the limb's circumference, the measured pressure will be artifactually elevated. You get a falsely high reading. The ideal width should be about 40% of the limb circumference to ensure accuracy. Then there's photoplethysmography. This offers continuous, beat-to-beat, non-invasive monitoring.
Continuous, how does that work?
It uses infrared light transmission to estimate the amount of hemoglobin in, say, a finger, which directly correlates with blood volume. This happens under a servo-controlled cuff.
The servo-control.
Meaning a microprocessor-controlled feedback loop continuously adjusts the cuff pressure to keep the finger's blood volume constant. Under these conditions, the pressure in the cuff directly reflects the digital artery pressure. Generally, these measurements agree quite closely with invasive methods, but it's important to note they can be less accurate in patients with significant hypotension or hypothermia.
So that covers the non-invasive range. But what about when a patient's condition is truly critical? When you need incredibly precise, continuous data, minute by minute, that's when invasive monitoring comes in, correct?
Exactly. For critically ill patients, direct and continuous monitoring of arterial pressure is frequently done invasively. This involves inserting a small intra-arterial catheter.
An art line.
Precisely, an art line, which is then connected via fluid-filled tubing to an external strain gauge transducer. The transducer translates that physical pressure into an electrical signal, which is amplified and displayed as a continuous waveform on a monitor. Alongside the waveform, you get precise digital values for systolic, diastolic, and mean arterial pressures. The mean arterial pressure, or MAP, often the most clinically relevant, is calculated by electronically averaging the amplitude of that pressure waveform. Now, understanding the fidelity issues with these invasive systems is absolutely crucial for accurate interpretation, really key for that elite understanding.
Fidelity issues, like how accurate the signal is.
Exactly. The accuracy of this whole catheter tubing transducer system can be affected by the tubing's compliance, its stretchiness, and the properties of the transducer diaphragm. If the system is underdamped, meaning it has too much inertia, too much bounce, it'll tend to overshoot both the maximum positive and negative pressure deflections during systole and diastole.
So it reads too high and too low.
It results in an overestimation of systolic pressure and an underestimation of diastolic pressure. Conversely, if the system is overdamped, maybe there's an air bubble or the tubing is too compliant, the transducer diaphragm struggles to track those rapid pressure changes accurately. This leads to an underestimation of systolic pressure and an overestimation of diastolic pressure.
That sounds like it could significantly mislead a clinician if they're not careful about the waveform quality.
It absolutely could. But here's the critical takeaway for clinical decision-making, the really practical point. Even in an underdamped or overdamped system, the mean arterial pressure, MAP, will still be accurately recorded, assuming the system has been properly zeroed and calibrated.
Okay, so focus on the MAP.
Therefore, when using direct intra-arterial pressure monitoring, clinicians should primarily base their crucial decisions on the measured MAP. It is consistently the most reliable and accurate value provided by these systems. Regarding site selection, the radial artery at the wrist is the most common choice. It's accessible, relatively lower risk. Other sites include the femoral and axillary arteries. It's also important for clinicians to recognize site-dependent pressure differences. Central or aortic pressures differ slightly from peripheral pressures, like in the radial artery. This is due to the complex impedance and wave reflections in the arterial tree.
So the numbers aren't identical everywhere.
Generally, systolic pressures are higher and diastolic pressures are lower in the periphery compared to the aorta. However, critically, the mean pressure remains approximately the same across both central and more distal sites. Another reason to focus on the MAP.
Given how invasive this procedure is, putting a catheter right into an artery, what are the potential complications that clinicians really have to watch out for?
Yeah, the potential complications are definitely a significant consideration. Distal ischemia, meaning inadequate blood flow to the limb beyond the catheter insertion point, is an uncommon but serious complication.
Cutting off circulation.
Potentially, yes. Its incidence tends to increase with larger catheters and longer duration of placement. To minimize this risk, a 20-gauge or even smaller catheter is typically preferred for the radial artery, and the catheter should absolutely be removed as soon as clinically feasible. Furthermore, before insertion, adequate collateral blood flow to the hand or foot must be meticulously confirmed. For radial artery placement, clinicians perform a modified Allen test.
I've heard of that. Testing the other artery.
Yes, it assesses blood flow from the ulnar artery when the radial is compressed. Our sources highlight that using a Doppler stethoscope to listen for perfusion in the palmar arch vessels offers a more objective and reliable way to confirm this crucial collateral flow. Another potential complication is retrograde embolization.
Embolization.
Like a
Clot.
Or air bubbles, tiny air bubbles or minute clots traveling backward against the blood flow into the intracranial circulation. This can potentially cause strokes.
Wow, that's serious.
Extremely. To minimize this grave risk, extreme care must be taken to absolutely avoid flushing arterial lines if any air is visible in the system, and only small volumes of fluid, typically less than 5 millibals, should be used for flushing. Lastly, catheter-related infections are always a concern with any intravascular device. While bloodstream infection rates for arterial lines are relatively low, maybe 0.4% to 0.7%, the incidence does increase with longer duration of catheterization.
Okay, makes sense. Moving on from pressure, let's turn our attention to the heart's electrical activity. Electrocardiographic, or ECG, monitoring is truly fundamental in critical care. So what exactly does this device tell us about the heart signals? What are we reading?
The ECG fundamentally records the electrical activity that drives cardiac contraction by detecting subtle voltage changes on the body surface. A standard 3-lead ECG involves placing electrodes on the left arm, right arm, and left leg.
The classic triangle.
Exactly. That defines specific views of the heart's electrical activity known as leads 1, 2, and 3. These devices continuously display the ECG waveforms and are typically set with alarms that trigger if rate or rhythm abnormalities are detected. This continuous surveillance is widely applied in both critically ill and perioperative patients. It is truly essential for patients with acute coronary syndromes or those who've sustained a blunt myocardial injury, because dysrhythmia's abnormal heart rhythms are the most common lethal complication in these conditions.
So it's looking for dangerous rhythms.
Primarily, yes. But also, in patients experiencing shock or sepsis, dysrhythmias can arise from inadequate myocardial oxygen delivery or as an adverse effect of vasoactive drugs. So, timely detection and intervention based on ECG findings can prevent these serious, often life-threatening complications. And with appropriate computing hardware and software, continuous ST segment analysis can also be performed. That's vital for detecting ongoing myocardial ischemia or infarction heart attacks or lack of blood flow.
But there are even more advanced ECG approaches now, right? Beyond just the standard 3-lead. I think I've seen setups with more wires.
Absolutely. A full 12-lead ECG provides significantly more diagnostic information. It's essential for patients with suspected myocardial ischemia or for thoroughly ruling out cardiac complications in other acutely ill patients. And continuous monitoring of the 12-lead ECG can be particularly beneficial in specific high-risk patient populations. For instance, one study involving 185 vascular surgical patients revealed that continuous 12-lead ECG monitoring detected transient myocardial ischemic episodes in over 20% of them.
20%, that's quite high.
It is. And this study also had a surprising but crucial finding for anyone aiming for that elite understanding. The precordial lead V4, which is not routinely monitored with a standard 3-lead ECG, was the most sensitive for detecting perioperative ischemia and infarction. To reliably catch 95% of ischemic episodes, the study indicated that monitoring 2 or more precordial leads was actually necessary. Furthermore, another prospective observational study looked at 51 peripheral artery vascular surgery patients. They had continuous 12-lead ECG monitoring after surgery. It found that their ischemic load, basically the amount and duration of ST segment changes, was a very strong predictor of perioperative myocardial infarction.
Predicting heart attacks after surgery.
Exactly. And here's the truly crucial point for you. Ischemia was asymptomatic in 14 of the 17 patients identified.
Silent ischemia.
Precisely. Highlighting the immense value of this continuous monitoring as a silent warning tool, detecting problems before they become clinically apparent. This suggests that continuous 12-lead ECG monitoring offers greater sensitivity than 3-lead for detecting perioperative myocardial ischemia and could very well become standard for monitoring high-risk surgical patients in the future. Beyond these clinical applications, there's considerable interest in emerging computerized approaches. Analyzing ECG waveforms and patterns and uncover subtle, hidden information that might predict sudden cardiac death or the development of serious dysrhythmias.
Like finding hidden patterns.
Kind of. Patterns like repetitive changes in the T-wave shape, known as T-wave alternans, and analyzing the intricate variations in heart rate, known as heart rate variability. These represent a much deeper dive into the heart's electrical signals, pushing the boundaries of what ECG can tell us.
That's truly incredible how much information can be extracted from just these electrical signals. And this is where it gets really fascinating. The rise of smart systems. We're talking about algorithmic integrative monitoring, where software combines all this disparate data to give an even deeper picture. Feels like the future.
Indeed. These integrated monitoring systems use sophisticated software that takes multiple non-invasive vital signs, heart rate, respiratory rate, blood pressure, SpO2, temperature, and processes them all together. The goal is to produce a single parameter index, one number, for the early detection of physiological perturbations or instability.
How does it do that? AI?
Essentially, yes.
No.
The software fundamentally uses neural networking, a form of artificial intelligence, to develop a probabilistic model of normality based on a large patient training dataset. Any significant variance from this established model is then used to evaluate the probability that the patient's current vital signs are falling outside the normal range, signaling potential instability.
Okay, so it learns what's normal and flags deviations.
But here's the key advantage, the real innovation. An abnormal index can be triggered even if no single vital sign parameter is individually outside its normal range.
Wait, really? Even if everything looks normal?
Yes. It's the combined patterns of these parameters that, when analyzed together, are consistent with known patterns of instability or impending decline. This approach has been shown to be highly sensitive for detecting early physiological abnormalities that might precede hemodynamic instability, particularly in patients on step-down units. Studies have shown this significantly reduces overall patient instability by facilitating earlier identification and prompt appropriate intervention by the medical team.
It sounds like it's getting ahead of the curve, almost predicting problems before they become obvious. A true leap toward proactive care, especially for achieving that master-level vigilance.
Precisely. And the vast expansion of the electronic medical record, the EMR, is further accelerating the development and adoption of these algorithmic assessment tools for inpatient monitoring. A prime example is the Rothman Index, or RI. This is a proprietary data analysis toolkit that leverages the immense amount of data continuously pouring into the EMR in real time.
So it uses all that EMR data.
It encompasses vital signs, lab test values, cardiac rhythms, pulling it all together to provide a comprehensive global assessment of a patient's status. In its initial development, the Rothman Index showed strong concordance with the Modified Early Warning Score, MUWS system, which is designed to alert teams to clinical deterioration before major events like cardiac or pulmonary arrest. Subsequent research has further evaluated the RI's performance, showing its predictive power for readmission to surgical ICUs after surgery and for triggering rapid response team activations.
So it's proving itself in practice.
The evidence accumulated to date is quite compelling, although more work is still needed to evaluate its broad applicability across all patient populations. But we can certainly speculate that as EMR interfaces become even more sophisticated and data integration improves, we'll see more real-time data analysis software packages developed, providing even deeper, more nuanced insights into the continuous care of post-surgical patients. It's a significant step toward truly intelligent and proactive healthcare.
Let's transition now to part 2, diving deep into cardiac performance and oxygen delivery systems. And we simply must talk about the pulmonary artery catheter, the PIC, sometimes called the Swan-Ganz catheter.
That's right, the Swan-Ganz.
This device has an incredible history, and it seems there's been some serious, even passionate debate surrounding its use in modern medicine. It feels like a major chapter.
You're absolutely right. The PECIS story is a fascinating and, yes, controversial chapter in critical care history. It was introduced into clinical practice back in the 1970s. Initially, it was primarily for managing patients in cardiogenic shock and other acute cardiac diseases. However, its indications rapidly expanded over time to cover a broad variety of critical conditions. There was immense early enthusiasm.
People thought it was revolutionary.
Many clinicians, certainly in those early days and even some today, genuinely believed that the PECR provided invaluable, almost irreplaceable information for managing critically ill patients. But here's the significant, often uncomfortable point. Unambiguous supportive data for this widespread belief became increasingly scarce over time. In fact, multiple studies eventually suggested that routine bedside pulmonary artery catheterization might not benefit most critically ill patients and, in some cases, could even lead to serious complications.
Which leads to that crucial question.
Exactly. Why was there such a strong, enduring belief in its utility despite increasingly conflicting evidence? We'll definitely delve into that. But first, to understand what the PAIC aimed to do, we need to understand the fundamental determinants of cardiac performance. The heart's ability to pump blood effectively is this intricate integration of multiple mechanical and physiological parameters. It involves the heart itself and the whole circulatory system.
Okay.
These crucial factors include preload, contractility, and afterload.
Preload, contractility, afterload, the
Yeah,
big three.
Right. Preload, as described by Starling's law of the heart, refers to the stretch of the ventricular myocardial tissue just prior to contraction. The force with which the heart muscle contracts is directly dependent on this initial fiber length.
The more stretched, the stronger the snapback, kind of.
To a point, yes. Strictly speaking, preload is determined by the end diastolic volume, EDV, the volume of blood in the ventricle right at the end of relaxation, just before it squeezes. However, measuring EDV precisely is clinically challenging, so clinicians frequently use end diastolic pressure, EDP, as a more practical, albeit imperfect, surrogate.
Using pressure instead of volume.
Correct. For the right ventricle, central venous pressure, CVP, often approximates right ventricular EDP. For the left ventricle, pulmonary artery occlusion pressure, PAOP, measured by transiently inflating that little balloon on the PAIC in a small pulmonary artery branch, approximates left ventricular EDP. However, and this is crucial for any elite professional to recognize, there are significant limitations to using EDP as a preload surrogate.
That what I...
EDP is determined by both volume and diastolic compliance, the heart's stiffness or ability to stretch and fill. The relationship between EDP and true preload isn't linear, it's exponential. This means its utility as a surrogate marker is significantly limited, especially at extreme EDV values, very full or very empty.
So EDP isn't always a perfect indicator of how much blood is actually filling the heart. What about how strongly the heart actually contracts, its inherent pumping power?
That's contractility, defined as the inotropic state of the myocardium. Contractility increases when the force of ventricular contraction goes up, assuming both preload and afterload remain constant. Clinically, precisely quantifying contractility is challenging because almost all available measures are, to some degree, dependent on both preload and afterload. They influence each other.
Making it hard to isolate.
Exactly. Our sources illustrate this abstract concept using pressure-volume loops, graphs showing the pressure inside the ventricle against its volume during a single heartbeat. Small changes in preload or afterload will shift the point defining the end of systole on this loop. These end systolic points, when plotted, describe a straight line known as the end systolic pressure-volume line. A steeper slope of this line indicates greater contractility, a stronger pump action for a given volume.
Okay, I can visualize that. And the third factor was afterload.
Right, afterload. Another term derived from lab experiments that gets more complex in the body. In humans, afterload is the sum of forces resisting fiber shortening once systole begins. Essentially, the resistance the heart chamber, usually the left ventricle, must overcome to expel blood into the circulation. This resistance is influenced by several factors: the ventricle's chamber geometry, the intracavitary pressure it generates, and the arterial impedance within the systemic circulation.
A lot goes into it.
Yes. Since these are difficult to assess directly in a clinical setting, afterload is commonly approximated by calculating systemic vascular resistance, or SVR.
SVR. Heard that one before.
SVR is defined simply as the mean arterial pressure, MAP, divided by cardiac output, QT. It's a simplified but clinically useful estimate of the resistance the heart is pushing against.
That provides a much clearer picture of the heart's intricate mechanics.
Huh.
So getting back to the pacey itself, how is it actually inserted into a patient, and what does it physically look like? It sounds complex.
The PAT, in its most common form, has 4 distinct channels or lumens. One channel goes to a small balloon right at the catheter tip, which can be inflated with air via an attached syringe. Before insertion, the balloon's integrity is carefully checked to make sure it inflates smoothly and expands beyond the tip. That's crucial to minimize the risk of poking a hole in a vessel or the ventricle during advancement.
Right, safety first.
Absolutely. A second channel contains wires connected to a thermistor near the catheter tip. This is vital for measuring cardiac output using that thermodilution technique we'll talk about. The final 2 channels are for pressure monitoring and injecting things. One ends precisely at the catheter's tip, the distal port, and the other is situated about 20 centimeters back from the tip, the proximal port. For placement, you absolutely need access to the central venous circulation. This is typically achieved through the antecubital vein in the arm, the femoral vein in the leg, or the jugular or subclavian veins in the neck-chest area.
Which sites are preferred?
Percutaneous placement, meaning through the skin, particularly via either the jugular or subclavian vein, is generally preferred. Of these, the right internal jugular vein cannulation historically carried the lowest risk of mechanical complications because it has a relatively straight, direct path into the right atrium. While accidentally puncturing the nearby carotid artery is easier to control with pressure than a subclavian artery puncture, the subclavian vein offers more consistent anatomical landmarks, even in obese or swollen patients, as it stays attached deep under the clavicle. However, for any elite professional today, it's critical to note that ultrasonic guidance should be used routinely for jugular venipuncture.
Ultrasound helps find the vein.
Yes, it significantly enhances the safety and success of bedside placement, especially when traditional landmarks are difficult to feel or see.
And the actual step-by-step technique for getting the central axis, I've heard the term Seldinger technique used.
Yes. Central venous cannulation, which is how you get the access for the cauliflower, is almost universally done percutaneously using the Seldinger technique. It's a fundamental skill in critical care. First, a small bore hollow needle is inserted into the target vein. Once you get venous blood return, confirming you're in.
Okay.
A flexible tipped guide wire is carefully inserted through the needle's lumen and advanced into the vein. The needle is then safely removed, leaving only the guide wire in place.
The wire acts as a guide.
Exactly. Next, a dilator, a plastic catheter designed to gently enlarge the tissue tract, is advanced over the guide wire to create a pathway. After the dilator is removed, a larger bore introducer sheath, which is basically a conduit for the pala, is inserted over the guide wire into the vein. Finally, the guide wire is removed, leaving the sheath securely in place, and the pay itself is then inserted through that sheath.
Okay, the sheath is like the entry port.
Precisely. For the PAC's advancement, the distal port is connected to a transducer system to display continuous pressure readings, and the catheter is flushed. While constantly watching the pressure tracing on a monitor, the pack is carefully advanced, with the balloon initially deflated until you see characteristic respiratory excursions in the pressure waveform. At this point, the balloon is gently inflated, and the catheter is advanced further, with the clinician meticulously monitoring the pressures as it sequentially passes through different heart chambers.
You can see where it is by the pressure waveform.
Yes, you see characteristic waveforms, low, relatively flat pressure in the right atrium, a sharp increase with a broad range between systole and diastole as it enters the right ventricle. Then, in the main pulmonary arteries, systolic pressure stays high, but diastolic pressure significantly increases because the pulmonic valve closes behind it. Upon further advancement, with the balloon still inflated, you get a damped tracing. That indicates the wedged position. Remarkably, this provides an estimate of left atrial pressure, and by extension, left ventricular preload.
That's the PAOP, or wedge pressure.
Correct. And a crucial safety step, one that cannot be overemphasized: always deflate the balloon immediately after getting a wedge pressure reading. This prevents potentially catastrophic complications like pulmonary infarction or pulmonary artery rupture. Because of this risk, unnecessary PAOP measurements are generally discouraged.
It sounds like a remarkably intricate process to get that catheter into such a precise position. But once it is, it seems to provide a remarkable amount of information about the patient's hemodynamic status.
It absolutely does. Even in its simplest configuration, the PACI can provide clinicians with an extraordinary amount of information. And if very specialized modifications are used, even more data can be obtained in real time. By combining this direct PAC data with other essential measurements like blood hemoglobin concentration and oxyhemoglobin saturation, clinicians can also calculate powerful derived estimates of systemic oxygen transport and utilization. Table 13-1 in our source material comprehensively summarizes the direct and derived parameters obtainable by bedside PAC monitoring, along with their approximate normal ranges.
Like what? Give us some examples.
Oh, you get CVP, pulmonary artery pressure, PAP, PAOP, mixed venous oxygen saturation, SVO2, cardiac output, QT, and cardiac index, CI, right ventricular ejection fraction, RVEF, stroke volume, SV, systemic vascular resistance, SVR, and its index SVRI, pulmonary vascular resistance, PVR, and its index PVRI, right ventricular end diastolic volume, RVEDV, and then the oxygen parameter, systemic oxygen delivery, DO2, systemic oxygen utilization, VO2, oxygen extraction ratio, ER, and shunt fraction, QSQT.
Wow.
Each of these tells a different yet intricately interconnected story about the patient's overall cardiovascular and pulmonary status. It gives a truly comprehensive picture, which is why it was so appealing.
How exactly is cardiac output measured with the PIC? That seems like one of its primary functions, the thing everyone talks about.
Historically, before the PACI, determining cardiac output at the bedside was incredibly cumbersome. You often needed meticulous measurements of oxygen consumption using the Fick method, or complex spectrophotometric determination of indocyanine green dye dilution curves. Really involved. The thermodilution technique, however, which the PAPC enabled, made this measurement far simpler, reasonably accurate, and capable of being performed repetitively right at the bedside.
Thermodilution, using temperature.
Exactly. The principle is elegant. A bolus of an indicator, in this case, a cold fluid, typically saline, is rapidly injected and thoroughly mixed with blood flowing through the heart. A thermistor, a temperature-sensing device located near the distal end of the PACI, then detects the temperature changes downstream in the pulmonary artery. The area under the resulting time temperature curve is inversely related to the flow rate of the blood.
So, faster flow washes the cold away quicker.
Precisely. Larger volumes of indicator result in greater areas under the curve, and faster flow rates result in smaller areas under the curve as the cold fluid is quickly washed away. The precise mathematical relationship used is the Stewart-Hamilton equation. It factors in the volume and temperature of the indicator injected, the core body temperature, and specific constants for the properties of blood and the catheter. A microprocessor then rapidly solves this equation to give you the cardiac output value.
How accurate is it?
Well, it's generally accurate, but it does tend to systematically overestimate cardiac output, particularly at very low flow states. Blood temperature changes and the patient's breathing cycle can also subtly influence the measurement, so it's typically recommended to record the mean of 2 or 3 determinations obtained at random points in the respiratory cycle to ensure reliability. While using colder injectate theoretically increases the signal-to-noise ratio, most authorities now recommend using room temperature injectate, either normal saline or D5W, to minimize errors from the fluid warming up as it travels through the catheter before it even reaches the heart.
Makes sense. Any newer ways to do thermodilution?
Yes, there have been innovations that permit continuous measurement of cardiac output by thermodilution. Instead of injecting a bolus, tiny, imperceptible thermal transients are generated by heating the blood with a small filament on the peak positioned just upstream from the thermistor. By precisely correlating the current supplied to this heating element with the downstream blood temperature detected by the thermistor, it's possible to continuously estimate average blood flow. Studies show these continuous measurements agree well with the conventional bolus injection method.
So continuous is better.
Well, despite the appeal of continuous data, information is still lacking regarding whether this continuous monitoring capability actually provides significant clinical value or favorably improves patient outcomes compared to intermittent measurements. So the jury's still out on its necessity.
That's a lot of detail about how the PAC works. Let's talk about mixed venous oximetry, or SVO2. What crucial information does that provide for understanding the whole oxygen balance picture?
Mixed venous oximetry, SVO2, is a direct reflection of the balance between oxygen supply and demand throughout the entire body. It's fundamentally derived from the Fick equation, which elegantly relates oxygen consumption VO2 to cardiac output QT, and the difference in oxygen content between arterial blood CaO2 and mixed venous blood CVO2. Oxygen content in both arterial and venous blood is primarily a function of hemoglobin concentration, hemoglobin saturation, and the partial pressure of oxygen. Critically, the contribution of dissolved oxygen is negligible in most clinical situations. It's the oxygen bound to hemoglobin that really matters.
Okay.
If we rearrange the Fick equation, we can see that SVO2 is a direct function of the metabolic rate, VO2, cardiac output, QT, arterial oxygen saturation, SaO2, and hemoglobin concentration, HGB.
So it reflects all those factors combined.
Exactly. Therefore, subnormal SVO2 values are a clear warning sign. They can be caused by several things. Decreased cardiac output, maybe from heart failure or hypovolemia, decreased arterial oxygen saturation, perhaps due to lung disease, decreased hemoglobin, signaling anemia, or a significant increase in metabolic rate, like from seizures, fever, or severe inflammation. With a conventional PTO, SVO2 measurements require drawing a blood sample from the distal port and analyzing it in a blood gas analyzer. So it's intermittent, providing snapshots rather than continuous insights.
But you can get continuous SVO2 now.
Yes, a fifth channel can be added to the P-post specifically for continuous SVO2 monitoring. This channel contains fiber optic bundles that transmit and receive light, measuring hemoglobin saturation by reflectance spectrophotometry in real time. These continuous SVO2 devices provide measurements that agree quite closely with conventional lab analyses. But, and this is a big but, despite the theoretical appeal of continuous real-time feedback, data are currently lacking to definitively show that this continuous monitoring capability favorably improves patient outcomes.
So same story as continuous cardiac output. Nice tech, but maybe not improving survival.
Pretty much. One large study of over 3,000 cardiac surgery patients with either a standard or continuous SVO2 packs showed no difference in patient outcome, even though the continuous group had fewer blood gas draws and thermodilution measurements. Given that continuous SVO2 packs are more expensive, their routine use is generally not recommended without clear outcome benefits.
So continuous SVO2 hasn't really proven itself for better outcomes. What about SCVO2? I understand that's less invasive, measured from a central line, not a pack. Does that fare better in terms of guiding therapy?
That's an excellent point. SCVO2, or oxygen saturation measured in the right atrium or superior vena cava, generally correlates closely with SVO2 over a wide range of conditions, although some studies have questioned this correlation in specific, more severe contexts like septic shock. The major advantage of SCVO2 is its reduced invasiveness. Measuring it only requires a central venous catheter, not a full pack that goes through the heart.
Much less risky.
Right. This makes it a more practical and less risky option for guiding resuscitation. By using a central venous catheter equipped for fiber optic SCVO2 monitoring, it becomes possible to guide the resuscitation of patients in shock with a less invasive device. For example, the Comprehensive Surviving Sepsis Campaign International Guidelines, which define best practices for sepsis management, recommend specific goals during the initial 6 hours of resuscitation for sepsis-induced hypoperfusion.
What kind of goals?
Goals like maintaining a CVP of 8-12 millimeter Hg, a mean arterial pressure MAP of 65 millimeter G or greater, urine output of at least 0.5 millimeter Gs per hour, and critically an SCVO2 of 70% or an SVO2 of 65%. This highlights its practical and evidence-based application in guiding critical, time-sensitive resuscitation efforts.
Okay, so CVO2 has found a niche in sepsis protocols. Now, if we connect all this patch discussion back to the bigger picture, It's really clear that despite its initial sophistication and widespread adoption, the patch story is one of surprising controversy. It's fascinating how a device so central to critical care for decades can then face such intense scrutiny and eventually see its role dramatically redefined.
It is truly a remarkable narrative, almost a cautionary tale in some ways, within the evolution of critical care medicine. Despite the immense initial enthusiasm for the PACI in managing critically ill patients, a recurring and profoundly significant theme emerged. Numerous rigorous studies repeatedly failed to show definitively improved outcomes with its routine use. A major turning point was the observational study by Connors and colleagues back in the mid-90s. They evaluated the PACI's impact by comparing ICU patients who got a PAC within their first 24 hours versus those who didn't. Recognizing that sicker patients were naturally more likely to receive a PAC, they used sophisticated statistical methods to meticulously match patients for severity of illness. Their striking conclusion was that PAC placement was associated with a significant increase in the risk of mortality, even after carefully accounting for illness severity.
Wow, increased mortality. That's a bombshell finding.
It was a pivotal, almost shocking finding that really ignited the intense debate that followed for years.
That's a pretty strong finding for an observational study, even with good matching. What about randomized controlled trials? The RCTs, they're considered the absolute gold standard for establishing evidence of benefit, right?
Indeed. And several prospective randomized controlled trials, RCTs, have rigorously examined the PAC. Their cumulative findings are summarized in Table 13-2 in our source material, and the story they tell is remarkably consistent. For instance, earlier studies, like one by Pearson and Associates, were notably underpowered, only 226 patients, and their randomization was a bit compromised because doctors could exclude patients from the control group. Toman and coworkers did a larger trial, over 1,000 patients, but different anesthesiologists were assigned to different groups, potentially introducing bias. Plus, quite a few patients in the control CVP group still ended up needing a PAC anyway due to complications. Other single-institution studies, often focused on specific groups like vascular surgery patients, were also relatively underpowered and frequently excluded certain high-risk patients, like those with recent heart attacks. Across the board, these early trials consistently struggled to demonstrate a clear and unambiguous benefit from PAC use in terms of survival or major outcomes.
So the early evidence was already shaky.
Shaky or inconclusive, yes. Then came the largest and probably most influential RCT, specifically on the PACI, conducted by Sandham and Associates. They randomized nearly 2,000 high-risk surgical patients, ASA classes 3 and 4, meaning significant systemic disease, to either get a PAC or just a simpler CVP catheter. In the PAC-C group, they used a comprehensive physiologic goal-directed therapy protocol. Clinicians actively used the PAC data to guide interventions. The results were stark and widely impactful.
What did they find?
No differences in mortality at 30 days, 6 months, or even 12 months between the two groups. ICU length of stay was strikingly similar. And importantly, there was a significantly higher rate of pulmonary emboli blood clots in the lungs observed in the PAC-C group, 0.9%, compared to the CVP group, 0%.
Higher clots and no survival benefit. Yeah. That's damning.
While the study was criticized by some for maybe not including enough of the absolute highest risk patients, its overall message was profoundly powerful and really shifted the clinical consensus against routine PAC use.
And then came the Pac-Man trial.
Yeah.
Right? That was another absolutely massive study from the UK that added to this evidence base.
Yes, the Pac-Man trial was another landmark. A multi-center randomized trial across 65 UK hospitals involving over 1,000 critically ill ICU patients managed either with or without a PAC. A key difference from Sandham's study was that the specifics of clinical management were left largely to the discretion of the treating clinicians. There wasn't a strict, predefined protocol for how the PAC data should be used.
So more like real-world practice, perhaps.
Perhaps. The outcome was unequivocal. No difference in hospital mortality between the two groups. 68% mortality with PAC versus 66% without. However, there was a notable 9.5% complication rate directly associated with PAC insertion or use, although thankfully none of these complications were fatal. Despite these being critically ill patients with high mortality rates anyway, supporters of the PACI again cited methodological issues like loose inclusion criteria and the lack of a defined treatment protocol as reasons to question the findings. But the trend was becoming clear.
It really sounds like the evidence was piling up.
It was. To further consolidate things, a significant meta-analysis of 13 randomized studies encompassing over 5,000 patients was published in 2005. This comprehensive analysis included a broad spectrum of critically ill patients from different trials with varying goals and treatment strategies. It found that while PAC use was associated with increased use of inotropes and vasodilators, suggesting clinicians were indeed acting on the data,
Okay.
there were no differences in mortality or hospital length of stay between patients managed with or without a PAC. This further cemented the notion that more intervention based on PAC data did not equate to better outcomes in this general context. The ESCAPE trial, specifically looking at 433 patients with severe congestive heart failure, found no significant difference in days alive and out of hospital, nor in hospital mortality, between PAC-guided and clinically guided groups. Strikingly, adverse events were significantly more common in the PAC group, almost double. And finally, the HAC-TT trial from the prestigious ARDS Clinical Trials Network meticulously evaluated the PAC versus central venous catheters in 1,000 patients with acute lung injury using an explicit protocol.
What was the verdict there?
Same story. No difference in mortality, ventilation duration, ICU stay, or organ failure. But the PAC-C group experienced approximately twice as many catheter-related adverse events, mainly arrhythmias.
So the overwhelming conclusion from this extensive body of evidence truly seems to be, despite its long-standing presence in critical care, the routine use of the PAC-C simply cannot be justified by the available evidence. This is a profound shift, especially for anyone who trained when it was standard.
That is precisely the robust consensus that has emerged. Few subjects in critical care medicine have generated more emotional responses and fervent debate than the PACE-D. But as these numerous, well-designed studies clearly demonstrate, it is fundamentally not possible to show that therapy routinely directed by the PACE-D consistently saves lives when evaluated in large patient populations. Consequently, we've witnessed a marked and continuing decline in its use globally. The numbers dropped dramatically between the early 90s and mid-2000s. Based on the rigorous exclusion criteria in these pivotal trials, reasonable clinical criteria have now been suggested for perioperative monitoring without a PACE. Things like no anticipated major aortic surgery above the kidneys, no recent heart attack or severe heart failure, no unstable valve disease or angina. Basically reserving it for truly complex cardiac cases, maybe.
But if it doesn't clearly save lives, and even carries risks, why was it so immensely popular for so long? And why do some clinicians perhaps still cling to its use in certain situations? What explains this surprising lack of effectiveness, despite its technological sophistication? It feels like a puzzle.
There's no single, simple explanation, but several possibilities likely coexist, reflecting the complexity of critical care itself. It's a great question for someone striving for mastery. Firstly, despite being considered relatively safe, PAC insertion does have a finite incidence of serious complications. Ventricular arrhythmias, sepsis, central venous thrombosis, pulmonary arterial perforation, pulmonary embolism. It's plausible that the negative impact of these complications might in fact equal or even outweigh any subtle benefits of using the PAC to guide therapy in the general population.
The risks might cancel out the benefits.
Or worse. Secondly, the vast amount of data generated by the PAC, though extensive, can sometimes be inaccurate. This can lead to inappropriate therapeutic interventions based on flawed information. Even if the measurements are perfectly accurate, studies have unfortunately shown a concerning lack of consistent knowledge among some intensive care physicians regarding the proper interpretation of complex PAC data. Getting the numbers is one thing, knowing what they truly mean is another.
The interpretation piece is key.
Absolutely. Furthermore, our collective understanding of the truly optimal management for certain profound hemodynamic disturbances, particularly those associated with severe sepsis or septic shock, is still somewhat primitive despite decades of research. We're still learning. It's even possible that certain interventions prompted by PAC-C measurements, while seemingly logical at the time, might actually be subtly harmful to patients in specific clinical contexts. We just don't fully understand all the downstream effects. Ultimately, the marginal benefit, if any, derived from placing a PAC in the general critically ill population may simply be very small, perhaps too small to reliably detect in trials or to offset its inherent risks.
What about that idea of goal-directed therapy? Using the PAC to push numbers like oxygen delivery really high. Didn't that drive some of its use?
Yes, that was a significant part of the debate. One primary rationale for its use was to optimize cardiac output and systemic oxygen delivery, sometimes aiming for aggressive, supraphysiologic goals pushing DO2, VO2, and cardiac output far exceeding normal levels. While some early smaller studies provided initial support for this concept, subsequent larger and more rigorous trials did not confirm these benefits. A comprehensive meta-analysis ultimately concluded that interventions designed to achieve these supraphysiologic goals do not significantly reduce mortality rates in critically ill patients.
So pushing numbers super high wasn't the answer either.
Right. At this time, aggressive supraphysiologic resuscitation of patients in shock cannot be endorsed as a general strategy based on current evidence. However, and this is a crucial nuance, aggressive hemodynamic resuscitation, guided by sophisticated monitoring, may still be valuable, but perhaps only during certain very specific, critical, and time-limited periods.
Like a window of opportunity.
Exactly. Think the crucial first few hours after presentation with septic shock, or during particularly high-risk surgery. For example, the Rivers trial showed significantly improved survival for septic shock patients when resuscitation in the ED was guided by a strict protocol aiming for an SCVO2 greater than 70% early on. Similarly, a study using an ultrasound-based device to meticulously assess cardiac filling and stroke volume demonstrated that maximizing stroke volume intraoperatively resulted in fewer postoperative complications and shorter hospital stays. So the key insight, perhaps for the aspiring elite professional, might be that the value lies not in the PATI itself as a universal panacea, but in when and how the data generated by any appropriate monitoring is precisely utilized in targeted, evidence-based protocols during critical windows.
This raises an important question then. If the PATI isn't the holy grail, what's next? What are the less invasive ways doctors are now monitoring patients and assessing cardiac performance, pushing beyond the limits of older technologies? Where's the field going?
That's precisely the driving force behind the explosion of minimally invasive alternatives. Because of the cost, the inherent risks, and ultimately the questionable widespread benefits associated with the PATI, there's been immense interest in developing more practical and significantly less invasive means of comprehensive hemodynamic monitoring. While it's important to note that none of these newer methods fully render the standard PATI thermodilution technique obsolete, it still has its place, they are certainly contributing to substantial improvements in how we monitor hemodynamics at the bedside. One prominent approach is transpulmonary thermodilution, or TPTD.
Transpulmonary.
Yeah.
Across the lungs.
Exactly. Unlike the PACI, which measures temperature changes over a short distance within the heart, TPTD measures temperature changes from a cold bolus injected centrally, usually via a central venous catheter, but then detected by a special arterial thermistor on a dedicated arterial line, typically in the femoral artery. Both TPTD and standard PACI thermodilution still use the fundamental Stewart-Hamilton equation to calculate cardiac output. Studies have consistently shown that TPTD provides comparable cardiac output estimates to the PAS and is sensitive enough to accurately detect changes as small as 12%.
Sounds good, but what are the downsides?
Well, a critical limitation is the much larger blood circuit between the central injection point and the arterial thermistor. This means data can be quite challenging to interpret accurately in certain complex conditions, like pulmonary edema, where all that excess lung water acts as a significant temperature sink, distorting the curve. On the upside, TPTD uniquely provides estimates of global end-diastolic volume, GEDV, reflecting total heart preload, and extravascular lung water volume, EVLW, a direct measure of fluid in the lungs.
Lung water, that sounds useful.
Potentially very useful, though these are primarily of scientific interest for now. More extensive studies are needed to confirm their widespread clinical utility in guiding therapy. But crucially, TPTD plays a prominent role in the real-time calibration of pulse contour analysis systems, which is another major area.
So TPTD offers cardiac output and some advanced volume measurements, but it's still somewhat invasive, needing a central line and a special arterial line. What about truly non-invasive or even much less invasive methods that provide similar insights into flow?
That brings us to Doppler ultrasonography, a remarkably versatile technology. This technique cleverly leverages the Doppler shift principle.
Like a weather radar for blood.
Kind of. When ultrasonic sound waves are emitted and bounce off moving red blood cells, the frequency of the reflected signal changes. This Doppler shift is directly determined by whether the cells are moving toward or away from the probe, and by their velocity. Knowing the vessel's cross-sectional area and the mean red blood cell velocity, you can accurately calculate the blood flow rate. If the vessel is the aorta, cardiac output can then be calculated using a formula involving heart rate, aortic area, and the integrated velocity over the heartbeat.
How do you use Doppler clinically for this?
Two main approaches exist. The first involves manually positioning an ultrasonic transducer in the suprasternal notch, right above the breastbone, aiming to focus on the aortic root. Aortic area is then estimated using standard charts or 2D ultrasound. While this is completely non-invasive, it requires a highly skilled operator and is relatively labor-intensive. Unless you use an independent cardiac output measurement to back calculate the aortic diameter, its accuracy isn't consistently acceptable for precise clinical decisions. It's mainly useful for intermittent checks, not really continuous monitoring.
Okay, so maybe not ideal for the ICU. What's the other way?
A more promising, though slightly more invasive approach uses a continuous wave Doppler transducer inserted into the esophagus, like a T-probe, but simpler. It monitors blood flow velocity in the descending thoracic aorta.
Esophageal Doppler.
Right. This provides a continuous, real-time display of the velocity profile and a calculated cardiac output. To optimize accuracy, the probe position needs to be carefully adjusted for the maximal signal, and a correction factor is usually applied to estimate total aortic flow from descending aortic flow. A meta-analysis has shown good correlation with PADI-EASE measurements. This device also calculates flow time corrected, FTC, the systolic flow time corrected for heart rate. This gives useful insights into preload, contractility, and vascular impedance.
Has this shown actual benefits?
Yes, critically, Doppler-based stroke volume and FTC have been successfully used to guide volume resuscitation in high-risk surgical patients, leading to measurable reductions in postoperative complications and shorter hospital stays. This application is a very promising and impactful area for Doppler monitoring.
I've also heard of impedance cardiography. How does that technique work? And is it considered reliable for those crucial clinical decisions we keep talking about?
Impedance cardiography measures bioimpedance, essentially, how electrical current flows through the body, specifically the thorax. Changes in blood volume and velocity within the aorta and major vessels lead to detectable changes in the thoracic bioimpedance. The first derivative of the oscillating component of this signal, dZdt, is directly related to aortic blood flow. Empirically derived formulas then use this to estimate stroke volume and cardiac output non-invasively and continuously.
Sounds appealing, non-invasive, continuous.
It is inherently attractive for those reasons. No extensive training, no catheters. However, our sources unequivocally state that measurements of cardiac output obtained by traditional impedance cardiography are not sufficiently reliable for guiding crucial clinical decision-making. They've consistently shown poor correlation with thermodilution, our clinical gold standard.
So the basic version isn't quite there yet.
Not for high-stakes decisions. Because of these significant limitations, a newer, more refined approach called bioreactance was developed.
Bioreactance. How's that different?
This method recognizes that the impedance signal actually has two components, amplitude and phase. While the amplitude is influenced by everything in the chest, the crucial insight is that the phase shifts are determined entirely by pulsatil flow, mostly from the aorta. Therefore, the bioreactance signal correlates more closely and accurately with aortic flow. Cardiac output measurements using this newer approach have demonstrated close agreement with conventional indicator dilution techniques. This represents a much more reliable and clinically promising evolution of the bioimpedance concept.
What about pulse contour analysis? That sounds like it might use the existing arterial line waveform, which would be a huge advantage for patients who already have one placed for blood pressure.
Precisely. Pulse contour analysis is another powerful method for continuously determining cardiac output, estimating stroke volume on a beat-to-beat basis. The fundamental principle is that the precise shape of the arterial pulse waveform that squiggle on the monitor is directly determined by the mechanical properties of the arterial tree and the stroke volume. This method uses the detailed arterial pressure waveform from an existing art line as input for a sophisticated computational model of the systemic circulation to determine beat-to-beat flow.
So it models the circulation based on the pressure wave.
Exactly. Initial parameters for this model, like resistance and compliance, are estimated based on the patient's age and sex, and then critically refined and adjusted using a reference standard cardiac output measurement obtained periodically using an indicator dilution approach.
It needs calibration.
Yes, calibration is key for accuracy. One commercial system uses the lithium ion, Li+, as the indicator. A tiny amount is injected into a peripheral vein and detected by the arterial catheter. This Li+ dilution method has proven reliable. Another system uses a conventional bolus of cold fluid for calibration via transpulmonary thermodilution, TPTD, which we discussed earlier. When pulse contour analysis is combined with intermittent TPTD, the continuous data from the contour analysis is significantly more precise and responsive than TPTD alone.
And how accurate are these calibrated systems?
Measurements of cardiac output based on these calibrated pulse contour monitoring approaches are widely considered comparable in accuracy to standard PIC thermodilution methods. patients. The key clinical advantage is being considerably less invasive. No need for that catheter through the heart. The computerized algorithms can continuously calculate stroke volume, cardiac output, SVR, and even estimate myocardial contractility by analyzing how fast the arterial pressure rises during systole EPDT.
What about uncalibrated versions, or using finger pressure?
There's research into using non-invasive photoplethysmographic arterial pressure from a finger for pulse contour, but its accuracy for this purpose has been questioned, and its widespread clinical utility is still TBD. Some uncalibrated devices on the market rely solely on proprietary algorithms and basic biometric data. While they're gaining acceptance, their reported accuracy is often not very good compared to gold standard approaches. So, for reliable, actionable data that an elite professional would trust, calibration with a reference standard is absolutely key.
Okay, so lots of progress on less invasive cardiac output. What about partial carbon dioxide rebreathing? That sounds quite unique, maybe tied to the ventilator somehow.
It is, and it's quite clever in its application. Partial carbon dioxide rebreathing is a non-invasive method that uses the fundamental Fick principle relating flow, consumption production, and concentration difference to estimate cardiac output. It works by intermittently altering the dead space within the patient's ventilator circuit using a special rebreathing valve. By precisely measuring the resulting changes in carbon dioxide production, VCO2, and end-tidal CO2, PET CO2, cardiac output can be determined using a modified Fick equation. Basically, Q equal VCO2 ATCO2.
Measuring CO2 changes to estimate blood flow. Interesting.
Commercially available devices leverage this using a CO2 sensor, an airflow sensor, and a pulse oximeter. However, a critical limitation is that changes in intrapulmonary shunt blood bypassing the lungs' gas exchange units and severe hemodynamic instability can significantly impair the accuracy of cardiac output estimated this way. To partially compensate, continuous inline pulse oximetry and FiO2 are used to estimate the shunt fraction for correction.
How well does it work compared to others?
Our sources present conflicting evidence. Some studies suggest it's not as accurate as gold standard thermodilution, while others indicate it compares favorably to PAC measurements in certain critically ill patient populations. So the jury is still somewhat out on its widespread universal reliability, but it represents an interesting non-invasive approach, particularly for ventilated patients.
And transesophageal echocardiography, or TE. I thought that was primarily an operating room tool, mainly for heart surgery. Has it moved into the critical care setting more broadly?
TE has indeed made a significant and increasingly common transition from being primarily an OR tool to becoming a powerful diagnostic and monitoring instrument in the ICU. For the procedure, the patient typically needs to be sedated and usually intubated to protect their airway. But using this powerful ultrasound technology, looking at the heart from the esophagus, clinicians can get incredibly detailed global assessments of both left and right ventricular function.
What kind of details?
Precise determinations of ventricular volume, ejection fraction, EF, and cardiac output. TE can also readily identify critical abnormalities like segmental wall motion issues, suggesting ischemia, pericardial effusions, fluid around the heart, and cardiac tamponade, pressure on the heart from that fluid. Advanced Doppler techniques within TE even allow for accurate estimation of atrial filling pressures.
What are the downsides in the ICU?
The main challenges are that the technique can be somewhat cumbersome to perform repeatedly at the bedside, and it requires considerable training and skill to obtain consistently reliable, high-quality images and interpretations. It's not something just anyone can do. However, a recent innovation is the introduction of a smaller T probe designed to be left in place for an extended period, potentially up to 72 hours. While only limited data are available for this extended use probe so far, it shows promise as a highly useful cardiac monitoring tool for selected, complex patients who require prolonged, detailed cardiac assessment.
So you can measure cardiac output with all these devices. You can even estimate heart volumes with some. But how do you know if giving more fluid will actually help a patient improve their cardiac output? That seems like a truly critical piece of the puzzle for anyone managing fluids. Assessing preload responsiveness, not just preload itself.
This is an absolutely crucial distinction, and it highlights one of the major limitations of older static monitoring parameters. You've nailed a key point for advanced practice. While devices can estimate stroke volume and cardiac output, they alone often offer little direct information about the adequacy of preload or, more importantly, whether adding more fluid will actually translate into increased cardiac output. Many clinicians historically assess preload using central venous pressure, CVP, or pulmonary artery occlusion pressure, PAOP, but these static pressure measurements have consistently been shown to correlate poorly with the true parameter of interest, which is left ventricular end diastolic volume, LVEDV.
So CVP and PAP aren't great for predicting fluid response.
While extremely high or low CVP-PAOP values can certainly be informative red flags, the large middle zone, typically 5 to 20 millimole Hg, is much less useful for guiding fluid therapy. Furthermore, critically, even changes in CVP or PAOP fail to correlate well with changes in stroke volume. Giving fluid and seeing the CVP go up doesn't reliably tell you the stroke volume went up.
Okay.
Even echocardiography, though it can estimate LVEDV, is skill-dependent, and isolated measurements typically do not reliably predict the hemodynamic response to giving more fluid. This is where dynamic predictors of fluid responsiveness truly shine and represent a major leap forward in understanding hemodynamics.
Dynamic predictors, like looking at changes over time.
Exactly, specifically changes related to breathing. For mechanically ventilated patients, pulse pressure variation, or PPV, is a very powerful and widely used dynamic predictor. The principle is that during positive pressure ventilation, the increased pressure in the chest intermittently decreases venous return to the heart. This in turn leads to a subtle decrease in left ventricular stroke volume, LVSV, during the inspiratory phase of the breath.
The ventilator breath squeezes the heart return.
In a way, yes. PPV is precisely defined as the difference between the maximal and minimal pulse pressures during the respiratory cycle, divided by their average, as shown clearly in figure 13-4. This dynamic approach has been rigorously validated as a strong predictor of cardiac output responsiveness to fluid challenges. Patients are classified as preload responsive if their cardiac index increases by at least 15% after a rapid intravenous fluid infusion.
And PVV predicts that responsiveness.
Yes. Receiver operating characteristic ROC curves, which assess diagnostic accuracy, have consistently demonstrated that PPV was the best predictor of fluid responsiveness when compared to traditional static measures like CVP, PAOP, and even simple systolic pressure variation.
So it's much better than just looking at CVP.
Significantly better for predicting response in ventilated patients. While atrial arrhythmias can interfere with its usefulness, PPV's simplicity, non-invasiveness, if an arterial line is already present, and reliability make it an invaluable approach for assessing preload responsiveness in the majority of mechanically ventilated patients. It's a key tool for rational fluid management.
That's a huge shift from just looking at static numbers to these dynamic real-time indicators. It's about predicting how the patient will respond to an intervention. What about monitoring tissue oxygenation more directly, getting beyond just central blood flow and pressures, and looking right down at the tissue level?
That leads us nicely to near-infrared spectroscopic measurement of tissue hemoglobin oxygen saturation, or SCHWARTZ. NIRS allows for continuous non-invasive measurement of tissue hemoglobin oxygen saturation using near-infrared wavelengths of light, specifically between 700 and 1,000 nanometers.
Near-infrared, like night vision almost.
Sort of. It uses light we can't see. The technology is based on Beer's law, a fundamental principle of light absorption, which states that light transmission through a solution decreases exponentially as the solute's concentration increases. In living mammalian tissue, 3 key compounds change their absorption pattern when they are oxygenated: cytochrome 3 in mitochondria, myoglobin in muscle, and hemoglobin in blood. Because oxyhemoglobin and deoxyhemoglobin have distinct absorption spectra at these specific wavelengths, NIRS can precisely detect their relative concentrations within the tissue being measured.
So it sees the oxygen level in the tissue itself.
It primarily reflects the venous side of the microcirculation within that tissue. Since roughly 20% of blood volume in tissue is arterial, and SCHWARTZ measures continuously without regard to the cardiac cycle, spectroscopic measurements are mainly indicative of the venous oxyhemoglobin concentration. This gives us a window into how much oxygen the tissue is actually extracting.
How has this been evaluated clinically?
NIRS has been rigorously evaluated for assessing traumatic shock. Studies in animal models of hemorrhagic shock consistently showed that peripheral muscle SCHWARTZ measurements were as accurate as other critical resuscitation endpoints like base deficit and mixed venous oxygen saturation in reflecting the severity of shock. In human blunt trauma patients, continuously measured SEPTO2 was evaluated as a powerful predictor for developing multiple organ dysfunction syndrome, MODS, and mortality. Using a cutoff of SEPTO2 S of 5%, it showed similar sensitivity and specificity to a base deficit SDO-per-AT-well in predicting both MODS and mortality.
So it's comparable to invasive measures like base deficit.
In terms of prediction in those studies, yes. The significant clinical advantages are that it provides a continuous and completely non-invasive readout of tissue oxygenation. Ongoing prospective studies are meticulously aimed at determining the full clinical utility of continuous SDO2 monitoring in a range of critical scenarios. Trauma, hemorrhagic shock, sepsis, where early detection of tissue hypoperfusion is absolutely paramount. It's a promising tool for looking directly at the end organ level.
Now, moving from the heart and direct tissue perfusion, let's talk about the lungs. What makes monitoring respiratory function so utterly crucial, especially in critically ill patients who might be on mechanical ventilation? It seems just as vital as the heart.
Monitoring respiratory function is absolutely of paramount importance in critically ill patients, especially those dependent on mechanical ventilation. You really can't separate the heart and lungs in critical care. It's essential for assessing the adequacy of both oxygenation, getting oxygen in, and ventilation, getting CO2 out, for guiding the complex process of weaning patients from the ventilator, and for detecting any adverse events associated with their respiratory status or the ventilator itself. Key parameters here include detailed gas exchange measurements, assessment of neuromuscular activity, breathing effort, precise respiratory mechanics, how the lungs and chest wall move, and evaluation of the patient's own respiratory effort if they're assisting the ventilator.
And the classic tool here is arterial blood gases, ABGs.
ABGs remain a foundational tool, yes. They provide vital information not just for respiratory failure, but also for detecting complex acid-base imbalances caused by all sorts of critical illness. Low cardiac output, sepsis, renal failure, trauma, overdose, altered mental status. ABGs directly measure pH, pHu2, P22, bicarbonate HCO3, and a calculated base deficit. Sometimes carboxyhemoglobin and methemoglobin levels can also be measured if specific poisonings are suspected.
We're doing fewer ABGs now.
There has been a concerted effort to decrease unnecessary ABG use. Frequent serial determinations are often not needed for routine weaning in most postoperative patients. Simpler, less invasive methods like pulse oximetry and capnography often suffice. While most ABG analyses still involve drawing blood, continuous bedside arterial blood gas determinations are now possible using an indwelling arterial catheter with a special biosensor.
Continuous ABGs without drawing blood.
Yes. Studies comparing this continuous monitoring to conventional lab analyzers have shown excellent agreement. This innovation can significantly reduce blood loss from frequent phlebotomy and dramatically decrease the time it takes to get critical results back, enabling faster decision-making.
But it's not common yet.
It remains an expensive technology and is not yet widely employed, still mostly research or very specialized centers.
You mentioned earlier that the primary goal of the whole system is oxygen delivery, DO2. How do these respiratory parameters specifically contribute to that overall picture?
Right. DO2, as we discussed, is primarily dependent on the oxygen saturation of hemoglobin in arterial blood, SiO2, much more so than just the partial pressure of oxygen, PaO2. It also, of course, crucially depends on cardiac output, QT, and hemoglobin concentration, HGB. Dissolved oxygen contributes very little. In mechanically ventilated patients, SO2 is directly influenced by the mean airway pressure the ventilator applies, the fraction of inspired oxygen, FiO2, being delivered, and the mixed venous oxygen saturation, SVO2, reflecting tissue oxygen use.
So multiple factors affect saturation.
Absolutely. So if a patient's SO2 is low, clinicians have a limited but critical number of levers to pull to try and improve it. They can increase mean airway pressure, usually by increasing positive end expiratory pressure, PEEP, or sometimes by extending inspiratory time. They can increase the FiO2, the oxygen percentage, up to 1.0 or 100%, or they can try to increase SVO2, which might involve interventions to increase hemoglobin or cardiac output, or sometimes by decreasing the body's overall oxygen utilization with things like muscle relaxants and sedation.
It really underscores that managing oxygen delivery is a systemic problem, doesn't it? Not just a lung problem in isolation.
Precisely. You have to think about the lungs, the pump, the blood, and the tissues all together.
Beyond just oxygen delivery and blood gases, ventilators also measure pressures within the airways. What are peak and plateau airway pressure, and what critical insights do they offer about the lungs themselves? Seems important for avoiding damage.
Airway pressures are absolutely routinely monitored in mechanically ventilated patients because they provide vital clues about lung mechanics and potential harm. The peak airway pressure, P peak, is the highest pressure measured right at the very end of inspiration. It's a dynamic parameter influenced by the tidal volume being delivered, the resistance within the airways like bronchospasm or a blocked tube, the overall compliance, stiffness of both the lung tissue and the chest wall, and the peak inspiratory flow rate. In contrast, the plateau airway pressure, plateau, is a static parameter. It's measured at the end of inspiration when the inhaled volume is briefly held in the lungs. The ventilator pauses flow for a moment before expiration.
An inspiratory hold maneuver.
Exactly. This means plateau is independent of airway resistance and peak airflow. It primarily reflects the static compliance of the lung and chest wall unit relative to the delivered tidal volume. Ventilators continuously monitor P peak, often with alarms. Plateau is typically measured intermittently by the clinician performing that hold maneuver.
How do you interpret these pressures together? This seems key for that elite understanding of ventilation.
Interpreting the relationship between P peak and P plateau is absolutely crucial for accurate diagnosis, as outlined in Table 13-4. If both P peak and P plateau are increased, assuming tidal volume isn't excessive, the underlying problem indicates decreased compliance. The lungs or chest wall are stiffer. Common causes include ARDS, severe abdominal distension pushing up the diaphragm, intrinsic PEEP or auto-PEEP, trapped air, pneumothorax, hemothorax, lobar collapse, atelectasis, pulmonary edema, pneumonia, or even active contraction of chest wall muscles fighting the ventilator.
Okay, high both means stiff lungs chest.
Right. If, however, P peak is significantly increased, but P plateau remains relatively normal, this clearly points to the primary problem being increased airway resistance. Think bronchospasm, a small or kinked obstructed endotracheal tube.
High peak, normal plateau means resistance problem.
Precisely. And a suddenly low P peak should also trigger an immediate alarm, as it strongly suggests a leak or disconnection in the airway circuit.
And this directly relates to something called ventilator-induced lung injury, or VILI, which sounds incredibly serious for already vulnerable patients. How do these pressures help prevent that?
VILI is indeed a very serious and well-established clinical entity, profoundly relevant to critically ill patients on ventilators. It refers to the damage caused to the lungs when excessive airway pressure and/or tidal volume are used during mechanical ventilation. These mechanical forces adversely affect the lung tissue itself, the parenchyma, and can also trigger systemic inflammatory responses throughout the body, making critical illness worse. Subjecting the lungs to excessive pressure, barotrauma, or excessive volume, polytrauma, can result in direct injury, diffuse alveolar damage that looks just like ARDS, pneumothorax, and can even critically impair venous return to the heart, limiting cardiac output.
So the ventilator itself can hurt the lungs.
If not used carefully, yes. To prevent VLI and dramatically improve patient outcomes, lung protective ventilation strategies have been rigorously developed and widely adopted. The standard of care now, particularly in patients with ARDS, unequivocally involves limiting plateau airway pressure to less than 30 centimeter H2O and restricting tidal volume to less than 6 millikilogram of ideal body weight.
Low volume, low pressure.
Relatively low, yes. In a large, pivotal, multi-center trial, this lung protective strategy significantly reduced 28-day mortality by 22% compared to a traditional, higher 12 millikg tidal volume strategy for ARDS patients. And recent data have further solidified this approach, suggesting that this lung protective strategy improves clinical outcomes even in ventilated patients without ARDS. Importantly, for high-risk surgical patients under general anesthesia, applying these principles leads to fewer post-operative pulmonary complications and shorter hospital stays. It stands as a critical example of how precise monitoring of respiratory mechanics directly guides protective interventions that save lives and improve recovery, a cornerstone of modern critical care.
Okay, let's shift to something ubiquitous. You've probably seen these little devices on your finger at the doctor's office, maybe even have one at home now. The pulse oximeter. How does this tiny device do so much, and why is it considered such a breakthrough in patient safety? It seems so simple.
The pulse oximeter is truly one of the most important and transformative technological advances in patient monitoring in modern medicine. Don't let its simplicity fool you. It's a microprocessor-based device that elegantly integrates oximetry, measuring oxygen saturation, and plethysmography, measuring blood volume changes, to provide continuous, non-invasive monitoring of arterial oxygen saturation, SaO2. It works by placing light-emitting diodes and sensors on the skin, typically a finger, toe, or earlobe. It emits two specific wavelengths of light, 660 nanometers, red, and 940 nanometers, infrared.
Red and infrared.
Right. It then analyzes the pulsatile component of blood flow, the changes in light absorption that occur with each heartbeat as blood pulses through the tissue. Because oxyhemoglobin, carrying oxygen, and deoxyhemoglobin, without oxygen, have distinct absorption spectra at these two specific wavelengths, the differential absorption of light allows the device to precisely calculate the fraction of oxygen saturation of hemoglobin, the SpO2 reading.
Clever. But are there limitations? Things an elite professional needs to know.
Absolutely. You must be keenly aware of its limitations. If carboxyhemoglobin levels are elevated, for example, in carbon monoxide poisoning the pulse oximeter, unfortunately misinterprets carboxyhemoglobin as oxyhemoglobin. This leads to a falsely elevated SpO2 reading, which can be dangerously misleading.
So few poisoning fools it.
Yes. Similarly, if methemoglobin concentration is markedly increased, certain drugs or toxins can cause this, the SpO2 displayed will often default to around 85%, regardless of the true arterial saturation, again providing inaccurate information. Additionally, the accuracy of pulse oximetry begins to decline significantly at SO2 values less than 92% and becomes increasingly unreliable for values less than 85%.
So it's less accurate when oxygen is really low.
Generally, yes. Despite these specific limitations, its clinical impact is enormous. Studies have consistently shown that continuous pulse oximetry monitoring in surgical patients significantly reduces unrecognized physiological deterioration, decreases rescue events, and reduces transfers to the ICU. Because of its profound clinical relevance, ease of use, non-invasive nature, and impressive cost-effectiveness, pulse oximetry has become an absolute routine monitoring strategy for virtually all patients with respiratory disease, all intubated patients, and all those undergoing sedation or general anesthesia. It's especially useful for precisely titrating FiO2 and PEEP during mechanical ventilation and weaning, and its widespread use has, in fact, significantly decreased the need for frequent invasive ABG determinations. It is, without exaggeration, an invaluable safety net.
So if a simple pulse oximeter can measure oxygen saturation non-invasively, can we expand that technology to measure other blood components, like overall hemoglobin concentration, without needing repeated blood draws? That seems like the next logical step.
That's where pulse co-oximetry comes in, representing an exciting extension of the original pulse oximetry technology. While basic pulse oximeters are great for SO2, pulse co-oximeters use multiple additional wavelengths of light beyond the standard 2.
More wavelengths give more info.
Exactly. This allows clinicians to leverage the different absorption patterns of various forms of hemoglobin to get a more complete readout, including an estimate of the total hemoglobin concentration in a given volume. This leads to a truly non-invasive measurement of total hemoglobin, not just oxygen saturation. These devices are specifically called co-oximeters because they can also measure other hemoglobin moieties like carboxyhemoglobin and methemoglobin more accurately than a standard pulse oximeter can. There are commercial devices available now.
What are the potential benefits of non-invasive hemoglobin?
Theoretically, the benefits are huge, eliminating the need for serial, painful blood draws, allowing extremely early detection of potential post-surgical hemorrhage, promoting a much more judicious and precise use of blood transfusions, avoiding unnecessary ones and their risks.
But how accurate is it in practice? Does it work reliably?
That's the current challenge. Multiple factors affect its absolute accuracy. Studies have shown biases, particularly that non-invasive hemoglobin monitoring tends to be inversely correlated with the actual hemoglobin concentration. Meaning, as the true hemoglobin value decreases, these non-invasive approaches tend to overestimate it. They read higher than the actual value, especially in anemic patients. This poses a significant challenge for critically ill patients who are frequently anemic and where precise hemoglobin values are paramount.
So it might overestimate low hemoglobin? That's not ideal.
It's a major limitation for absolute accuracy. On the other hand, even if the absolute accuracy is lower at low hemoglobin levels, the continuous monitoring capacity might still provide clinically useful trending data. It might allow clinicians to see if a patient's hemoglobin is falling rapidly, even if the exact number isn't perfectly precise.
So the trend might be more useful than the specific number.
Potentially. To date, though, relatively few studies have fully validated this trending capacity compared to serial gold standard blood draws. There's limited agreement across existing studies due to differences in analysis and design. So further rigorous studies are definitely required to fully evaluate the clinical utility of this potentially very useful technology. Promising, but needs more validation.
Let's turn to capnometry now. It sounds like it's about what you're breathing out rather than what's going in or how much is flowing, measuring CO2.
That's an excellent way to think about it. Capnometry is the precise measurement of carbon dioxide in the airway throughout the entire respiratory cycle. It's most commonly measured using infrared light absorption because CO2 specifically absorbs infrared light at a particular wavelength. The device works by passing infrared light through a sample chamber containing the patient's exhaled gas to a detector. The more infrared light that reaches the detector, the less CO2 is present in the sample. The partial pressure of CO2 in the end tidal exhaled gas, the gas at the very end of exhalation called PET CO2, is often used as a convenient surrogate for the partial pressure of CO2 in arterial blood, or PaCO2, particularly during mechanical ventilation.
So PET CO2 approximates PaCO2.
In healthy subjects, PET CO2 is usually about 1 to 5 millimillichi less than PaCO2, allowing it to provide a non-invasive estimate of arterial CO2 without a blood draw. However, and this is a crucial point for advanced understanding, changes in PaCO2 may not always reliably correlate with changes in PaCO2 during various pathological conditions, especially lung disease or shock. So clinical caution and context are always needed.
What about continuous monitoring, capnography?
Yes, capnography, which is continuous capnometry displayed as a waveform over time, is absolutely essential for confirming correct endotracheal intubation, making sure the breathing tube is in the windpipe, not the esophagus. That's probably its most critical use.
A lifesaver right there.
Absolutely. It also provides continuous real-time assessment of ventilation adequacy, the integrity of the airway circuit, proper ventilator operation, and even gives indirect clues about cardiopulmonary function. Capnometers come with either an inline sensor, part of the main breathing circuit, bulkier but less prone to clogging, or a side stream sensor, pulls off a small sample via thin tubing, lighter but the tubing can clog with secretions or water. Continuous capnography has become mandatory and routine during surgery under general anesthesia and for many intensive care patients due to its immediate ability to promptly detect several critical life-threatening situations.
Like what kind of situation?
For example, a sudden sharp reduction in PaCO2 can immediately indicate a critical problem. It might just be obstruction of the sampling tubing, but more gravely, it could signal a catastrophic event like loss of the airway, complete airway disconnection or obstruction, ventilator malfunction, or, critically, a marked and sudden decrease in cardiac output.
Low CO2 can mean the heart stopped pumping blood to the lungs.
Exactly. If the airway and ventilator are confirmed to be fine, a sudden significant drop in PaCO2 should immediately prompt urgent efforts to rule out cardiac arrest, a massive pulmonary embolism, or cardiogenic shock. These all drastically reduce blood flow to the lungs and thus CO2 delivery to the exhaled breath. Conversely, persistently low PaCO2 might indicate hyperventilation, breathing off too much CO2, or increased dead space ventilation, like with smaller pulmonary emboli. An increase in PaCO2 suggests reduced minute ventilation, not breathing enough, or an increased metabolic rate, producing more CO2. It is a quick, remarkably insightful, real-time window into both ventilation and even systemic hemodynamics.
Moving from the respiratory system now. The kidneys are often seen by clinicians as vital barometers, right?
Mm-hmm.
Critical indicators of overall patient status and perfusion. How do we monitor renal function in these complex, critically ill patients?
You're right. The kidneys are exquisitely sensitive to systemic changes in blood flow and oxygen delivery, making them invaluable indicators of overall perfusion. The most basic, ubiquitous, and widely used method for renal monitoring is simply assessing urine output. This is typically recorded hourly via an indwelling Foley catheter. With a patent Foley, urine output serves as a gross but immediate indicator of renal perfusion.
How much urine is normal?
Normal urine output for adults is generally accepted as N.5 milliliter a year per hour. For neonates and infants, it's higher, maybe 1 to 2 milliliters per hour. Oliguria, which means low urine output, can immediately reflect inadequate renal artery perfusion, maybe due to hypotension, hypovolemia, or low cardiac output. It can also, of course, be a sign of intrinsic renal dysfunction where the kidney itself is damaged.
But normal urine output doesn't guarantee the kidneys are okay.
That's a crucial point for an elite professional to recognize. Normal urine output does not exclude the possibility of impending renal failure. Significant renal damage can occur before urine output drops noticeably. It's often a late sign of trouble.
Okay. What about monitoring related to abdominal compartment syndrome? You mentioned that earlier with airway pressures.
Yes, a more specific and critical type of renal-related monitoring involves measuring bladder pressure, particularly in the context of abdominal compartment syndrome, or ACS. ACS is a life-threatening condition defined by that triad: oliguria, low urine output, elevated peak airway pressures on the ventilator, and elevated intra-abdominal pressure, IAP.
Pressure building up inside the belly.
Exactly. This syndrome, first described after complex abdominal surgeries like AAA repair, arises from severe interstitial edema swelling of the abdominal organs, which drives up the pressure inside the abdomen. When this IAP rises and exceeds the venous or capillary pressures within the abdomen, it critically impairs perfusion to the kidneys and other vital intra-abdominal organs. Oliguria, therefore, is often a cardinal and early sign of this impaired perfusion due to compression.
How do you measure that abdominal pressure?
While ACS is primarily a clinical diagnosis based on signs and symptoms, measuring IAP is absolutely crucial for confirmation. In practice, transurethral bladder pressure measurement is most often employed as a simple yet effective surrogate to reflect IAP.
Measuring pressure in the bladder tells you the pressure in the whole abdomen.
It reflects it quite well, yes. It involves instilling a small volume, typically 50 to 100 millibarias of sterile saline into the bladder via the Foley catheter, and then connecting the drainage tubing to a pressure transducer to measure the bladder pressure while the patient is lying flat at the end of expiration.
That's quite clever and direct.
Mm-hmm.
What are the specific pressure thresholds clinicians look for to diagnose problems?
Good question. Intra-abdominal hypertension, IAH, is formally defined as an IAP of 12 millimilli Hg or greater, recorded on 3 standard measurements taken 4 to 6 hours apart. It's then separated into several grades, I to IV, based on the pressure level, table 13-5. The actual diagnosis of abdominal compartment syndrome, ACS, is even more critical. It requires an IAP of 20 millimilli Hg or greater, again confirmed by 3 measurements 1 to 6 hours apart, plus evidence of new onset organ dysfunction directly attributable to that elevated pressure.
So high pressure plus organ damage equals ACS.
Exactly. Less commonly, gastric pressures or pressures measured directly in the inferior vena cava via special catheters can also be monitored, but bladder pressure remains the most common, practical, and validated method in clinical use for assessing IAT.
Finally, let's talk about neurologic monitoring. The brain is uniquely vulnerable, isn't it? Rigidly confined inside the bony skull. So what does all this complex monitoring mean for keeping the brain safe, especially in critical conditions where swelling or injury is a major threat? How do we protect the command center?
The brain's unique environment within that rigid, unyielding bony skull means that any cerebral edema, swelling, or mass lesions, like a bleed or tumor, can rapidly and dangerously increase intracranial pressure, or ICP. Monitoring ICP is currently a standard of care recommended in patients with severe traumatic brain injury, TBI, specifically those with a Glasgow Coma Scale, GCS, score of 8 or less, and an abnormal head CT scan.
GCS less than 8, bad CT.
Right. It's also indicated in severe TBI patients who might have a normal CT scan but exhibit 2 or more specific risk factors, like being over 40, showing motor posturing, abnormal body positions indicating brain damage, or having a systolic blood pressure less than 90 millimilli Hg. Other important indications for ICP monitoring include acute subarachnoid hemorrhage with coma or deterioration, intracranial hemorrhage with blood in the ventricles, large ischemic strokes causing significant swelling, fulminant hepatic failure causing coma and brain swelling, and global cerebral ischemia or anoxia resulting in cerebral edema.
So lots of reasons to monitor brain pressure. What's the goal?
The overriding goal of ICP monitoring is to ensure adequate cerebral perfusion pressure, or CPP. That's the critical pressure gradient driving blood flow to the brain. CPP is simply calculated as the mean arterial pressure, MAP, minus the ICP. Maintaining adequate CPP is absolutely paramount to prevent secondary brain injury from lack of blood flow.
And how do they actually measure ICP? What are the precise devices used inside the skull? It sounds quite invasive.
It is invasive, yes. One primary and widely accepted type of ICP measuring device is the ventriculostomy catheter, often called an EVD or external ventricular drain. This is a small, fluid-filled catheter inserted directly into one of the cerebral ventricles, those fluid-filled spaces deep within the brain, and connected via tubing to an external pressure transducer.
What are the advantages of that?
Its advantages are significant and multifaceted. It not only provides accurate, continuous ICP measurements, but also allows for therapeutic drainage of cerebrospinal fluid, CSF, to actively lower ICP when it rises too high. Plus, it can be used for CSF sampling for lab tests if infection or other issues are suspected. Because of its accuracy, the ability to drain CSF, and a relatively low complication rate compared to other invasive methods, ventriculostomy catheters are considered the accepted standard for monitoring ICP in TBI patients. Other devices involve placing a transducer directly within the CNS, maybe in the brain parenchyma tissue, the subdural space or the epidural space, but these typically only monitor ICP without offering that crucial CSF drainage capability.
Are there significant risks with the ventriculostomy?
Like any invasive procedure, yes, it's associated with potential complications. These include infection, occurring in around 5% of cases, hemorrhage, about 1.1%, and catheter malfunction or obstruction, ranging from 6.3% to 10.5%, as well as the potential for malposition with inadvertent injury to brain tissue during insertion.
So the purpose is clear. Detect and treat abnormal ICP to maintain CPP. But a critical question for any elite professional aiming to master this must be, does treating the ICP number actually improve patient outcomes consistently? This also seems to be an area of ongoing debate and complexity, much like the PASI.
It is indeed a critical and complex question that again underscores the nuances of critical care. In TBI patients, an ICP consistently greater than 20 mmHg is robustly associated with unfavorable outcomes, increased mortality, worse neurological recovery. No doubt about that correlation. However, surprisingly, few studies have definitively shown that the direct, aggressive treatment of elevated ICP improves clinical outcomes in human trauma patients across the board. It's harder to prove causation than correlation. One pivotal randomized trial by Eisenberg and colleagues did demonstrate that meticulously maintaining ICP below certain thresholds, less than 25 mmHg without craniectomy, less than 15 mmHg with craniectomy, was associated with improved patient outcome. For patients with low cerebral perfusion pressure, CPP, therapeutic strategies typically aim to either increase mean arterial pressure, MAP using vasopressors, or decrease ICP using various methods like CSF drainage or medications.
But the target CPP number is debated.
While maintaining CPP between 50 and 70 mmHg has been widely recommended, the direct evidence rigorously supporting this specific CPP target range for improved outcomes is, frankly, not overly compelling in all contexts. It's likely more individualized. And here's a surprising and thought-provoking finding from a retrospective study. ICP-CPP targeted neurointensive care was associated with prolonged mechanical ventilation and increased therapeutic interventions, but without clear evidence for improved outcome in patients who survived beyond 24 hours.
More intervention, not necessarily better results.
Again, it highlights that profound challenge. Simply measuring more parameters and intervening more aggressively doesn't always automatically translate into guaranteed clinical benefits unless the precise interpretation and intervention strategies are clearly and rigorously validated. It suggests, again, that a deeper understanding of the meaning of the data, rather than just the data itself, is crucial for truly effective care.
Beyond just pressure inside the skull, what about monitoring the brain's actual electrical activity? That seems fundamental to its function.
That's where electroencephalogram, EEG, and evoked potentials come in. EEG monitors the global neurologic electrical activity, specifically from the cerebral cortex, the brain's surface. Continuous EEG, CEG, in the ICU is particularly useful for ongoing evaluation in obtunded and comatose patients, for meticulously monitoring therapy for conditions like status epilepticus, continuous seizures, for detecting early cerebral ischemia that might not be apparent otherwise, and for precisely adjusting sedation levels, especially when high-dose barbiturate therapy is used to lower critically elevated ICP.
So it sees seizures, ischemia, sedation levels.
Yes. Evoked potentials like somatosensory evoked potentials, testing nerve pathways from limb to brain, and brainstem auditory evoked potentials, testing hearing pathways, measure the brain's electrical activity in response to specific sensory stimuli. They are less affected by sedatives than EEG. They're useful for localizing brainstem lesions, for helping prove the absence of structural lesions in metabolic or toxic coma, and for providing crucial prognostic data in post-traumatic coma patients.
Is there anything newer in EEG for sedation?
Yes, an important and increasingly utilized advance in EEG monitoring specifically for sedation purposes is the bispectral index, or BIS monitor.
BIS monitoring.
Heard of that? It's specifically used to precisely titrate the level of sedative medications. While sedation is often guided by clinical exam alone, BIS has been widely used in the OR to continuously monitor the depth of anesthesia. The BIS is an empirical measurement, statistically derived from a vast database of over 5,000 EEGs. It's calculated from bifrontal EEG recordings, meticulously analyzing parameters like burst suppression, periods of brain inactivity, the relative amounts of different brainwave frequencies, alpha to beta ratio, and by coherence, how synchronized different parts are. It boils all that down to a single linear numeric index from 0 flat EEG to 100 fully awake.
So a number for level of consciousness.
Essentially, yes, reflecting sedation depth. Its use has been consistently associated with lower anesthetic consumption, earlier awakening from anesthesia, and faster overall recovery. Critically, it has also been rigorously validated as a useful approach for monitoring the level of sedation for ICU patients, using standard clinical sedation scales as the benchmark.
What about transcranial Doppler ultrasonography, or TCD? Is that also for brain monitoring, maybe looking at blood flow velocity?
Yes, transcranial Doppler TCD ultrasonography offers a unique, non-invasive method for evaluating cerebral hemodynamics, the blood flow within the brain. TCD specifically measures blood flow velocity in the major arteries inside the brain, like the middle and anterior cerebral arteries, by sending ultrasound through thin parts of the skull.
What's it used for?
It is particularly useful for diagnosing cerebral vasospasm after subarachnoid hemorrhage. A significant increase in middle cerebral artery mean flow velocity, as measured by TCD, is a strong predictor of symptomatic vasospasm, which can cause strokes days after the initial bleed.
But can it measure ICP or CPP?
That's an important limitation. Despite some proposals, studies have clearly shown that TCD is not a reliable method for estimating ICP and CPP. It currently cannot be endorsed for this purpose by any elite professional relying on solid evidence. Beyond vasospasm, TCD is also valuable for confirming clinical examination findings when determining brain death, especially if confounding factors like CNS depressants or metabolic problems make the exam difficult. It provides objective evidence of absent cerebral blood flow.
And jugular venous oximetry, or SJO2, measuring oxygen in the vein draining the brain. How did that reflect brain oxygenation, and where does it fit into the bigger picture?
Jugular venous oximetry, SJO2, offers a fascinating window into the overall balance of oxygen supply and demand within the brain itself. It essentially reflects changes in global cerebral blood flow when arterial oxygen content, hemoglobin, and the oxygen dissociation curve are relatively constant.
How do you interpret it?
Generally, a decrease in SJO2 suggests cerebral hypoperfusion. The brain isn't getting enough blood flow and is extracting more oxygen. An increase suggests hyperemia, or excessive blood flow relative to metabolic need. However, it's crucial to understand its limitation. It cannot detect decreases in regional cerebral blood flow if the overall global perfusion is normal or even high. It averages the whole brain.
How is it measured?
It requires placing a specialized catheter in the jugular bulb, that small dilation at the base of the skull where venous blood collects before leaving the head, usually accessed via the internal jugular vein. Both intermittent blood sampling and continuous fiber optic oximetry catheters are available. Studies have indeed shown that persistently low SJO2 is associated with poor outcomes after traumatic brain injury. Nevertheless, the independent value of monitoring SJO2 as a standalone technique remains unproven.
So, like the PAC-C, maybe not a magic bullet on its own.
Exactly. If employed, it should not be the sole monitoring technique, but rather used in conjunction with more established ICP and CPP monitoring. However, when ICP, CPP, and SJO2 are monitored together as part of an integrated, protocolized approach, early intervention with fluids, vasopressors, maybe adjusting ventilation, has been shown to help prevent ischemic events in TBI patients. This suggests its value lies in that combined multimodal approach, giving a more complete picture.
Another near-infrared technology, transcranial near-infrared spectroscopy, NIRS for the brain. Is that similar to the tissue oxygen saturation we discussed earlier for muscle, but specifically adapted for the head?
It is indeed very similar in principle. Transcranial near-infrared spectroscopy, NIRS, is a non-invasive, continuous monitoring method specifically designed to determine cerebral oxygenation. It employs technology remarkably similar to pulse oximetry and muscle STO2 monitoring, using near-infrared light and sensors placed on the scalp. It takes advantage of the relative transparency of the skull to light in the near-infrared spectrum to estimate the concentrations of oxy and deoxyhemoglobin within the underlying brain tissue.
What's the potential use?
The underlying idea is that continuous monitoring of cerebral perfusion and oxygenation via transcranial NIRS might provide a rapid and non-invasive way to detect early cerebral ischemia areas of insufficient blood flow in patients with TBI, maybe before global changes occur.
Is it widely used?
Currently, however, this form of monitoring largely remains a research tool. Its widespread clinical utility is still being rigorously investigated. Interestingly, though, some authors have recently reported its potential as a very promising triage tool for pre-hospital care in TBI.
Triage, like in the ambulance.
Potentially, allowing for rapid, non-invasive screening for intracranial hematoma bleeding at the scene. 2 small EMS studies have suggested its feasibility as a valuable adjunct, particularly in remote settings or when CT scanners aren't immediately available, providing a quick initial assessment. Still early days, but interesting potential.
Okay, finally. We've talked about pressure, global blood flow, electrical activity, even average venous oxygen in the brain. But what about measuring direct oxygen levels within the brain tissue itself? This sounds like it could be a potential missing piece in preventing that secondary brain injury everyone fears.
You've hit on a very cutting-edge and increasingly promising area: brain tissue oxygen tension monitoring, or PbTO2. While standard care for severe TBI involves monitoring ICP and CPP, this strategy alone doesn't always reliably prevent secondary brain injury. As we discussed, this injury can be caused by localized areas of ischemia that global ICP-CPP monitoring might simply miss. Growing evidence strongly suggests that monitoring local PbTO2, using a probe placed directly into the brain tissue, may be a remarkably useful adjunct to standard ICP monitoring in these patients.
What are normal PbTO2 levels?
Normal values are typically between 20 and 40 millimary Hg. Critical ischemic levels where damage is likely occurring fall around 8 to 10 millimilli Hg.
Has this shown benefits in studies?
Yes. A recent clinical study rigorously aimed to determine if adding a PbTO2 monitor to guide therapy in severe TBI was associated with improved patient outcomes. In this observational study, 28 severe TBI patients received both ICP and PbTO2 monitoring and were meticulously compared to 25 historical controls who only had ICT monitoring. Therapy goals for both groups included keeping ICP below 20 millimilli Hg and CPP above 60 millimilli Hg. But critically, for the PbTO2 monitored group, therapy also aimed to maintain PbTO2 above 25 millimilli Hg, directly targeting tissue oxygenation.
Love the results.
The results were truly compelling. While both groups had similar mean daily ICP and CPP levels, the mortality rate in the historical controls treated with standard ICP-CPP management alone was 44%. In stark contrast, mortality was significantly lower in the patients whose therapy was guided by PbTO2 monitoring in addition to ICP and CPP, only 25%.
Wow, a big difference in mortality by adding that direct tissue oxygen target.
It suggests profound benefits. PbTO2 monitoring may allow early and precise detection of brain tissue ischemia, even when ICP and CPP levels look normal, catching problems before they become widespread. It might also help reduce potential adverse effects associated with overly aggressive ICP-CPP management, allowing for more targeted and precise interventions based on the brain's actual oxygen needs at the tissue level. This really does seem like a crucial step towards preventing devastating secondary brain injury that current standard monitoring might simply miss. It empowers clinicians to make truly elite, data-driven decisions focused on the ultimate goal: protecting brain tissue.
Wow. What an exhaustive and truly insightful deep dive into the human body's most critical systems and how we monitor them. When you step back and look at all these sources, all this evolution, what stands out to you as the most profound, overarching conclusion? How far have we truly come in physiologic monitoring?
That's a great question. What stands out most profoundly, I think, from all these sources is the undeniable truth that modern intensive care is truly predicated on our ability to continuously monitor a wide range of physiological parameters in real time. This capability has undeniably and dramatically improved the care of critically ill patients. It has fundamentally advanced critical care medicine as a distinct and sophisticated specialty. No question about that. However, a consistent, recurring theme emerges from this deep dive. In some cases, our sheer technological ability to precisely measure these variables has, ironically, surpassed our understanding of their exact clinical significance, or maybe even our collective knowledge of the most appropriate evidence-based interventions to correct the problems we detect.
We can measure more than we always know what to do with.
Sometimes, yes. This intellectual gap remains a critical challenge for the entire field. We are now capable of collecting vast amounts of data, but the wisdom and precision of how to best interpret and act upon it is still rapidly evolving. Mastering this field isn't just about knowing the tech, it's about knowing the limitations and the evidence. The recognition of serious complications associated with older, more invasive monitoring devices, particularly the pulmonary artery catheter, has been a significant and positive driving force. It's pushed the relentless development and adoption of safer, less invasive methods. The future, therefore, clearly points towards the continued development of highly accurate, non-invasive or minimally invasive monitoring devices. But crucially, also their application within meticulously designed, evidence-based strategies to truly guide rational and impactful therapy. It's about discerning smart data, not just accumulating more data.
That's a powerful synthesis. As we've seen throughout this conversation, data alone isn't enough. Sophisticated interpretation, understanding the context, knowing the evidence, that is absolutely key. So, the next time you hear about some amazing new medical technology, perhaps you'll consider this. In a world awash in increasing data and ever more complex measurements, is our true challenge not just measuring more, but understanding better what those numbers really mean for an individual human life? And how might this profound shift in focus shape the skills, the knowledge, and the very mindset of tomorrow's elite medical professionals, pushing them beyond mere data collection to a deeper level of integrated insight and clinical wisdom? That's all for this deep dive. We encourage you to reflect on these insights and consider how this vital field continues to evolve, constantly striving to better understand and support the critically ill patient.